Mr. Landsman, Mr. Lindermeer,
Here.
Miss Namie Dyer,
Here.
Miss Newman,
She's just walking in.
Miss Root, Dr. Tom,
Here.
Mr. Torres,
He was going to be 30 minutes late.
Dr. Guadalupe,
Present virtually and excuse me. Can you hear me?
I can hear you, yes.
Okay, it's like my sorry. Seems like I was cutting out. Okay. For those of you that are present, I don't have, normally I can see you guys on the screen, but I can't see on the screen. So if anyone needs to interject, please just jump in today because I can't see anyone's hands. We'll move on to public comment. Is there any public comment?
There's no public comment at this time. However, we do have a second opportunity at the end of the meeting for public comment.
Thank you. All right. Our first item on our agenda, we have guest Ben Bodkin and Noah Smith to discuss capital services. So I will turn it over. Are they remotely or in person?
Sheila, they're in the building, but they're not in the boardroom. Here they come in now.
Okay, we'll hold just a second for them to get settled then. Thank you.
Well, hello.
Good evening. Is there a way to get a camera shot of the speakers, or is that not working tonight?
I'm not much to look at, I can promise you that.
No, it's always nice to be able to see folks that are, when they're talking, but if not, that's okay. And if you could just start by introducing yourself or your name, just for those of us that are virtual, and then we can get going. I appreciate it. Thank you.
All right. I am Ben Bodkin. I do government affairs services and consulting for Capital Services Incorporated in Lansing, Michigan, and have had a contract with OCHN for, at this point, I think going on 6 years now. And for all of those 6 years, we have battled some kind of a privatization proposal, it seems. And we have been successful so far in kind of holding that off. So that said, I'm going to talk a little bit more about that, but I want to talk about what's happening in the legislature, some other things before we go into that topic. Legislature is still on break right now, and they will come back in September. They do have a day scheduled on the 17th of this month, but it's looking more and more like that will not be a legislative day. They won't take attendance or have votes. So that said, September and October will be very, very busy. There is a budget that is still out for fiscal year 22 that needs to be done, and that is expected to be done in September because the budget has to start October 1, and the state has to have a budget to keep operating. If you remember way back when, a couple governors ago, we had an issue for about 3 hours one night where the government technically shut down, but we got through it okay. So I don't think that's going to happen this time. I think they're going to get it done. But September will be busy with budget negotiations, et cetera. October will also be a heavy legislative month. They'll be in all 4 weeks there. In November, they'll be in the front half of November, and then they'll be in the front half of December as well before the holidays. So that is what the rest of this year looks like, calendar year. We're still in the first year of a legislative session, so we still got another calendar year of the session available to us to work on. On the budget, nothing much has happened since last we've discussed it. It's kind of been on hold over the summer a little bit. I won't, don't take that the wrong way. They're still working on it. There's not been any procedural movement on the budget. So just to refresh your memory for fiscal year 22, the House did not include direct care worker wage pass-through. They put a $100 placeholder there in case there was money available. They did not include the local Medicaid match hold harmless language that we've had in the last couple of years. They did include CCBHC expansions and did not include uniform credentialing, which was some language that I think was probably something that we would like. The Senate kind of did all of the things. They included $2.35 wage pass-through for fiscal year 22, included the local Medicaid match protection, both money and boilerplate to protect that local money. Included CCBHC expansion and also included language on uniform credentialing. So I think all that is good. Obviously, I think we would probably prefer the Senate version if we have a choice, and we'll continue to work on that as we go forward. We have kind of a new tradition in Lansing on budgeting since the pandemic has hit, and that is the new tradition of constant supplemental process. Supplemental budget, as you may or may not know, is a supplemental appropriation for the current year that you're in, right? Or a previous year, could be too. Because state revenue has been so difficult to predict during the last year and a half or 2 years, they have kind of since December decided to govern by supplemental. So they pass a budget, and then every couple months they will pass a supplemental to kind of true up numbers, okay? So the good news is that there's always a chance to get something in the budget. The budget process isn't the end like it used to be for a year. The bad news is that you may also be fighting for things in the budget too, or bad things can pop up, right? So it's kind of a new thing. I would expect that it will go away once things kind of settle out again, and we're back to kind of stable, predictable revenue sources and that kind of thing. But that is kind of just a thing to be aware of, that we're doing a supplemental every couple of months, and it's just different. It's a different way to do things. Speaking of supplementals, there are 2 federal supplementals. One was passed in June before they left, and that was the supplemental from the federal money that was sent down in December. It was about $3 billion, I think, altogether. And there is another supplemental from the federal government sitting out there right now that came down in April and May. It's the same one that the counties are seeing money from right now, if you're aware of that. There's about $5.5 billion of federal money available to the state of Michigan for that. That has not been allocated yet either. I think just like the counties and local units are struggling with kind of what are the rules on this, right? What is this eligibility spent on? Nobody wants to pay money back to the federal government, and so I think that some of that is part of kind of what's been holding things up over the summer, is figuring out what that can be used for. Counties received about $1.9 billion in that, by the way, through a separate direct payments from the federal government to the counties. So with that, I'll switch over to the privatization issues that are before us. And please feel free to ask questions at any point as well. So there are two privatization proposals. I should say system change, I suppose, would be a more accurate term. The first one is a little easier to explain. It's Senator Shirkey, who is the majority leader in the Senate, has a proposal that's very much like the old 298 proposal. It would basically turn Medicaid dollars over to health plans rather than PIHPs. And so, you can, the same results that you would think of when we were talking about 298 and that kind of thing are results there. Same kind of idea. The other proposal is in the House, and that is Representative Whiteford, who is the DHHS subcommittee chair. She controls this DHHS subcommittee budget bills that go through the legislature in the House. And those bills, it's a four-bill package, 4925 to 29. Those bills would eliminate PIHPs and create a new entity that would be a statewide. Okay, so a state-level entity, but not a state entity, if that makes sense to you. It would be a contractual relationship between the state and this new entity that would act as a PIHP basically for the entire state. So we would go from 10 PIHPs basically to one, right, statewide, but it wouldn't be a PIHP. It's not necessarily public. No one really knows what it would look like, but the requirements seem to be that it would probably be some kind of private conglomerate, I guess. It would be the best way to put it. Yes?
I wasn't sure if you'd take go. So under this, the House bill, would we qualify to be that PIHP? I know for the Senate one we would not.
I don't believe so. I think it would be, it's a new entity, so it's not like the department would just contract with existing PIHPs. It's a whole new animal, I guess, right, so to speak. It's called a SIP. I think that's the term that's used in the bill. And so that's what it would be, and likely it would be private because of the amount of money that it requires to back it. It's likely going to be private. Although it doesn't say it has to be. But that's kind of, I think, what would happen. So the Senate bills, just so you have the numbers, are 597 and 598. It's two bills. One is Shirkey and one is Bizon, Senator Bizon. And those went to the Government Ops Committee, which is the committee that Senator Shirkey chairs in the Senate. In the House, the bills are 4925 to 29, and the sponsors are Whiteford, Hammoud, Phil Green, Aller, and Thanadar. So two Democrats, and then three Republicans on those bills. Those bills are in the House Health Policy Committee. They've had two hearings, the House bills have, and both of those were in June. I've not had a hearing since then. Some of the, I think some of the steam may be coming out of the House bills a little bit. There's a lot of anticipation on the Shirkey package from the Senate right now because it was just introduced a couple weeks ago, and we expect a large push by the majority leader in the fall on those bills. So would expect a lot of work to be done in September and October. With that, the fall is the timeline, I think, for these bills. Once we get past the fall, we're in an election season again, and things get harder to do. Not that they couldn't be done, but they get harder to do. And I think that momentum-wise, if something's going to be done, the next, the 8 weeks beginning September 1, and ending November 1 are going to be really critical for the public system. So that's just my belief. I think they're going to be a big push right now going forward. So dangers of these bills, I think, are similar. While one is, kind of outright privatization of the system, the other is centralization of the system, right? And I used to work at a place called Michigan Association of Counties for county commissioners, and I was not brought up to believe that centralizing power is really ever a good idea. that it's usually best implemented by those who have to live under it, right? And live under those rules and know what the problems are and where resources need to be directed locally. So I think we have similar outcomes from both of these packages. So some of those include obviously loss of the public safety net, loss of responsibility, right? Where does the buck stop, right? In both cases, I think it stops at an entity that's not responsible to anyone who's elected. It's certainly not responsible to anyone locally. If I have a problem with the care that my loved one is receiving, I can't come here and complain to you all, right, and get that fixed. If I live in Oakland, I'm going to have to find an advisory panel in Lansing that may or may not have any power to do anything for me. And I may be talking to an entity that points at the State Department, and then the State Department may point back at the entity, right? So where does that buck stop is a problem, certainly for those who use the system and who are served by the system. So that's, I think, a major piece. What happens to the services that you're providing in conjunction with courts and the educational system and others for jail services, prevention services, diversion courts, that kind of thing. Those aren't Medicaid dollars. However, will there be a CMH strong enough in the state to continue to provide those things with their general fund that they have? Will general funds still be provided, right? I mean, I don't know. I don't know what happens under that. Will the counties continue to put in money because they don't have any say anymore, right, under these proposals? So I don't know if the counties would still put money in. There are a lot of different kind of things to think about with this system. It's complicated, obviously, but that means that the potential issues that develop as a result of these good intentions may also have complicated problems going forward too. How do we provide access to social determinants of success, right? Those aren't Medicaid, there aren't billing codes for those, right? How do we provide transportation? How do we provide training? How do we provide jobs? How do we provide housing? How do we help people, manage day to day? And those are things that really help make people successful. And I don't think there are codes for those, but I could be wrong. But I don't think anyone's doing them like you're doing them, right, in this system. Loss of coordination of care and resource allocation, we kind of discussed that already, right? Locally, where dollars need to go. You need whether, percentage-wise, what should go into suicide prevention and what should go into SUD services. And, those kinds of decisions are made locally based on the need in this county. And those decisions are being made locally based on the needs of the counties and the PIHP districts around the state right now. And if we lose that ability, you're going to lose the ability to kind of fine-tune your services so that you get the best outcome for the most people, right? And some of that is layers of multiplication, right? If you're providing this service and this service, sometimes those can come together and really help in a community. And sometimes providing this service and that service, maybe they don't, right? Maybe we don't need this one so much. but we need more of these other two things. And you're able to really kind of pinpoint and target the dollars that you have. Loss of local infrastructure. So this is really one that's specific to you, because you have probably the most infrastructure in the state for the folks that you serve. And, you know, it may be you may have a situation similar to auto no fault where, you know, the providers that are providing services or the infrastructure that's being paid for today can't sustain itself any longer, right? So that's a concern as well. I'm sure there's more. You know, loss of revenue to the system. We know what your Medicaid loss ratio is. It's very low. I don't think you can beat that. So that's money coming out of the system if it's you know, a different administrator, and on, right? So I think based on the policy of it, it's really hard to find really good things about the proposals, and I think it's pretty clear that there are a lot of maybe perhaps dangerous things to the proposals that we need to work on. So, you know, what's the strategy? Where do we go from here, right? It's like you've got the timelines, you know, when things were introduced and what's happening this fall and that kind of thing. I have been a little dismayed to see that we have not had the reaction to these proposals, and maybe we will now that the Senate proposal is out. We haven't really had the reaction that we've had in past years to the 298 proposals, and really, we really need folks that are served by the system to speak up and understand what's at stake, and speak up and talk to folks. That's key. I mean, that has been the thing that has gotten the system through the last 5 or 6 years under threat of this kind of thing, and I think it can be successful again. So anything you can do to encourage that would be good, privately or publicly. We are looking all the time at building coalitions with other groups, other interest groups, other county-based interest groups, law enforcement, courts, et cetera, in order to kind of widen that net and help them understand what's at stake as well. Those discussions have been going pretty well. Stay tuned on that. And really we need, you know, PIHPs across the state to get involved. To date, it's been Dana, and she's doing great. She's doing a great job with folks. But we need all 10 involved, and we need to really target Southeast Michigan, and we need to really target rural Michigan. You know, those are the two places I think that really are losers under some of this, and I think, you know, if we can get PIHPs and those who are served by the system to really start speaking up and supplement that with some other groups, I think we can have a chance. We've done pretty good so far, but you know, we need to try to put this to bed so that we can talk about, you know, real positive change for the system and doing some really good things for folks in a better way statewide. So we're doing coalition meetings, coalition building. Dana has had, I don't know, 24 meetings or 36 meetings, I guess, in the last couple of months, 3 months, and those have gone well. I think she has met to date with everyone in Oakland that's a legislator, and leadership in committees that are of importance, and starting in on the rank and file of those committees now. So So that's been going well. We've gotten good reception from folks, but it would not hurt to hear from board members, so give your senators and representatives a call. They're here for you. They want to help, and tell them to be strong. So the question is, what's going to happen? And I can't tell you what's going to happen, right? That's the first question everyone will, is this going to be successful or not successful? And that's really up to how active people are, right? We're all given the same amount of time, so how are we going to use it? And how do we become too big to fail, right? So that's the idea. Just keep spreading the word. I think there are talking points and that kind of thing developed. So use those. Get out there. Talk to your mayors. Talk to everybody. Everybody that'll listen. Chiefs of police, judges, etc. Anyone that'll listen, especially those that touch the system, should be keenly interested and may not know they should be keenly interested. So, what are we trying to fix, right? We've had these proposals out here for a really long time. The question is, what is the problem that we're after, right? We keep hearing that the system is broken, the system is broken, and I work for you guys, so my experience is from OCHN's perspective, and I see a pretty good system in Oakland. I mean, I really do. And people at the state level say that all the time. Well, it's working. Well, yeah, it's working in Oakland, but in other places, it's like, okay, well, let's talk about how we improve the system then, and not toss out all the good stuff, right? So in working with Dana and her team, we've had several meetings with the department and other stakeholders to talk about what kind of positive options can we put on the table for really good systemic change, right? That doesn't upend everything and cause other problems. So, how do we increase access, right? So let's tackle access. Let's increase use of Care Connect 360, right? These are pretty old talking points. We've been pushing this a long time. We had boilerplate in the budget bill on one side for this for a long time. And you're seeing results from it. I mean, you're seeing measurable percentages, by the dozens of measurable percentages in hospital visits and, that kind of thing. Let's talk about paying for performance. That's a thing that only you're doing. No one's doing that, and they should be, right? I mean, this is a thing that improves outcomes. It improves the amount of money in the system, right? Because it drives any savings back in. These are great reforms that that I think we have a chance to implement, perhaps statewide. And these are things that could solve a lot of problems out there. How do we increase behavioral health homes and SUD health homes, right? So how do we do that? That's integrated care, right? That's integrated care. FQHCs, how do we get more of those, right? All of that stuff. And in case, this is a good talking point too, in case people are, think that we just are homers and we don't want to, give up the control and all that kind of thing. It's like, no, things that make sense to centralize, like credentialing, like training, recipient rights perhaps, let's centralize those. Like, I'm not afraid of that conversation, but let's not centralize the responsibility, because the responsibility has to lay somewhere local. I mean, that's just good governance, right? I mean, that's like Founders 101. I mean, that's, what are the incentives? And build the system to the incentives. The incentive is that people who have to live under a system will do it better, right? So it's not hard. We've just got to get the message out. And that's all I've got. I went for a good solid half hour, so I want to make sure that I leave any time for questions and don't take too much of your evening tonight.
Hi, I have a question.
So again, I can't,
Oh, is
sorry,
it-
Eric. No, I was just gonna
I'm
say, I
sorry.
can't see anyone there.
So I wondered if we could think a little bit about the types of things that the board could do in order to defeat this type of legislation. You talked about hearings. Are those hearings in Lansing? I would imagine with COVID, is it being done through taking testimony through Zoom, or how is that going? Or should we look at bringing legislators in here to meet with service recipients? Should we pen a statement to the Oakland Press where everybody on the board signs on to it as in the form of a letter to the editor? What are the kinds of strategies that we should be looking to implement, or at least support Dana and her team to implement?
Yeah, I think at this point, it would be really, really good for you all to be active in your respective communities, with folks, with other pillars of the community, right? Make some phone calls, talk to some folks. You have a statement, I believe, that you've done already, so that's a good thing. I think we could absolutely talk about letters to the editor and that kind of thing. You have folks that are here that are better experts at PR than I am. And so, I would defer that question to some of those folks. But certainly, the time is now over the next 10 weeks or 12 weeks to get this thing, to make your wishes known. So I think there are very few bad ideas at this point. The very few bad, honest ideas, put it that way, right? And I think that if you've got an idea, I would get it to Dana, yesterday, and let's talk about it for sure. Mhm.
Okay.
Are there
Ben,
other
I'm not-
questions from? Oh,
Yeah, there is, sir.
sorry.
It's Steve Taub. Ben, I know that Alan Bolter had sent out our automated thing, the voter voice thing, with the automated emails. I was wondering, since our board is at least half new members, I wonder if they're registered. Did the new board members get a thing from Alan Bolter from CMHA that you could just add your own comments to and then send on to your? Anyway, I did get it about 2 weeks ago and sent it in. And since I live in Bloomfield Township, which has got a mailing address of Bloomfield Hills, mine went also to a state senator, the Rosemary Bear, that is not my state senator, and she answered me actually, and said that she wasn't going to read automated emails, but she would count them. And I know a lot of people, even in Washington, they count every single email they get. So if you new members aren't registered with that voter voice thing that Alan Bolter has, contact CMHA and get your name on it. And every time he sends one out, you can do the easy thing is read the letter, and if you agree with it, just punch OK, and it goes to, they take your address and it goes to all your representatives, in my case, an extra one. And, or you can, at the beginning, you can add your own thoughts. And the staff will read them, and they do count them. And that's what happened on 298. They were pleading with, then weren't they saying, call off your people because we're getting all these emails. So that requires the people we serve to be involved also, not just 12 board members.
Yes.
I do know
those...
Sheila sent the list of all of our emails to CMHA, so I'm hopeful that all the new board members are receiving emails from them.
Yeah, I think those are important. Definitely, if you agree with that, I would go ahead and forward it along. it is better to make a personal phone call, or send a personal email, but I understand, you know, it's busy, but if you can't do both, do one, right? So, yeah, for sure.
Chair Malkaya has her hand up.
Okay.
Thank you, Jonathan. This time it's been different. Instead of trying to do it through boilerplate, they opted to introduce legislation to change the mental health code. And one of the things that I know Senator Shirkey's office did was put the fear of Shirkey in people early on, because even before the legislation came out, he met with advocates, and some of them came away from that meeting feeling like, well, let's not do anything, let's not, you know, get the people up in arms because there's no legislation. There's nothing to fight. So he was very intentional this time in how he did this. Wait to the last minute, get it on the table, and then everybody's got to scramble. I'm on the Behavioral Health Advisory Council, and there was nothing from the department to us about this, even though Shirkey's office said that he's consulting with us on this. So he doesn't really want the outcry because he knows what would happen. And I don't know. It really disturbs me greatly that he tried to shut down people from speaking by not putting the legislation out. Well, there's nothing to fight. He put the proposal out in May, but we're just now seeing the bills. So that put us at a disadvantage, because what are you going to say? There's nothing to fight. I really wish that there was an organized organization that just served the people we serve, because the advocates cannot speak for us the way that we can speak for ourselves. Now, Shirkey met with all of the advocacy agencies. They sent a letter back in May, but he doesn't want to talk to the people that are affected directly by this legislation. He's receiving money from these plans, as is Whiteford. So it's all about the money. It's not about fixing the system. And they're both term limited and desperate to get this through. So a lot of people are uncomfortable. I'm not throwing in the towel on it, but it disturbs me that people play with people's lives like they do, and then they're going to walk away. If this goes through, they're done. They don't have to pick up the pieces. They don't have to do anything. It'll be left to the ones that come behind, and that's disturbing to me. One proposal that I wanted to make, I know we're in the process of looking at our bylaws. I would like to propose that we start a work group on the board level that's just advocacy. So when it's ongoing, we have our PR work group, we have our advocacy work group for everybody, but most of the board doesn't participate at that level. I think we need a board advocacy work group that stays in place, that's always working on advocacy. So we don't have to try to get it together at the 0 hour, because his proposal came out in May, and I haven't heard enough. I know the board association is putting out stuff, but I still don't think there's been enough, especially for our newer board members, to understand the gravity of this. Because what are we going to look like? If Shirkey's proposal goes through, will there even be a need for OCHN? I don't know. And that's one of the questions I have for the finance department. If Whiteford's proposal goes through and they do away with the PIHPs, what are we going to look like? What will we be after that? And I don't think we know enough about what is in front of us to mount an intelligent defense. I'll just put it that way. And there was no question in there, was it?
No, ma'am.
Sarah? Jonathan?
All right. Yes. Go ahead.
So my question is, it's going to go into Shirky's, in that committee that Shirky's chair of, before it can ever go anywhere else. When are they planning, or when is it expected that they will have their public meetings, their committee meetings?
I would expect it'll be September.
So we have between now and then to bone up, get on that schedule to be there, and then from there, assuming it does pass, where does it go from his committee? Does it go right to the floor? Or
Right to
does
the
it go
floor.
to finance?
To the floor.
It goes to the floor. And that's not for this upcoming fiscal year then, it's for the following fiscal year, assuming our legislation goes through?
I have to look at the dates in the bill. I'm sorry. I feel like it's a year or two down the road when it becomes effective. It moves over different pieces of the mental health system a year at a time. I think it takes 3 to 4 years total. But don't quote me on that.
But it's not going to, even if it leaves his committee in September, October 1st, when we start our new fiscal year, it's not going to.
No.
Okay.
No, it would, they would start making preparations during the next fiscal year, certainly.
Okay, thank you. Back to you, sir.
Are there any other questions?
I had a question on a separate topic. Recently, money was passed, I think it was $4.4 billion of ESSER money there would be one-time money that could be used in school districts. And I know that some of the language that came out about what the money should be used for is mental health services for students and staff in public school districts. And I just wondered if you know what that process is for a school district. Maybe that's an opportunity for us to partner with some of the school districts that are in need to provide mental health services for kids and staff in schools.
Yeah, and I don't know a lot about it, but I can tell you I believe that money was for school psychologists and social workers. I believe, but I can go back and look. Let me go back and look and get you a better answer.
I can respond. Part of it is, that is one bill, and so it depends on how the dollars are funneled. And so for us, one of the things that we already are working with schools, so our providers are indirectly working when the schools, not necessarily through us. And so we now have an opportunity to actually present a proposal to the county to access ARP dollars as a part of the COVID response. So that's one way to do it. But also we have to look at some of the gaps. So these bills really dismantle the entire public system. So if we want to really strengthen what we do, we're really going to have to fill in our gaps and improve on those priority items that I talk about in terms of access and crisis, like Ben says. How do we improve on those things? But also when we look at access and using the no wrong door approach, if children are coming through us through the school system, how are we set up to make sure that we're responding in a way that gets their needs met? And we know, I don't think we even have any clue of what children are going to experience going back to school in September. It's going to be so traumatic for kids that have never gone to school, but also for kids returning to school. And just, we haven't even talked about the grief and loss process for children. So with this opportunity and others that are going to present themselves, we just have to be prepared with those proposals, and then also the ones we've already talked about before. So I think, it's one thing to have to fight these legislative things that are happening. It's another thing to hold up our house and continue to work through what we need to work through, especially with COVID. I mean, it's unquestionable the number of things that we need to do that we could focus on if we weren't up for these fights. And I agree with Ms. Newman wholeheartedly. Nobody's telling us what this will look like if these things actually pass. And I think for me personally and professionally, that's the scary part, is what happens to the people we serve and how does that impact their access to services and care. And so the example that Ben brought up is those other services. So we're not comparing apples to apples. The people we serve are the most vulnerable citizens in this community. And so I think they're focused on the mild to moderate and those basic outpatient services. But being a part of the public system and working in the public system for so long, I don't think there's ever been anybody that I work with to try to assist and support that I didn't do integrated care with. Because I had to not just say, okay, see you next week. It was a matter of, how did you get here? Where are you living? Do you have food? What kind of supports do you have? So I think we have to really focus with this fight about the services that we do provide as a public system and that we are doing integrated care. It's formal now, but, I think we've been doing it for a long time, and we don't really push our successes. It's easy to put a news program to show where there was a problem, but that's the exception. That's not the rule for the public system. And I think we don't do enough of highlighting all of the successes that there are. And so that fight has to really shine a light on what it is we do to help people.
Thank you, Dana. When Malachi was talking and talking about what happens to the service recipients when there's such a dramatic change, I had a flashback to the closing of Lafayette Clinic. When Lafayette Clinic was closed, there was no plan for the people that were in that clinic. And while that was probably a far abrupt service change than what we would eventually be looking at, I'll never forget what those service recipients went through. And if we have a chance to make sure that people don't feel that pain, I think we do have a responsibility to it.
All right, thank you. Any other comments or questions? Well, this was a great presentation. I think it's very important that we have all the updated information, so we appreciate your presentation and sharing all this information. And I think as board members and community members on the call, that they will be able to move forward to continue to advocate.
All right. Well, it's great to see everyone again in a real room. So it's exciting to come down. Thank you.
Thank you.
Thank you. Forward to our next agenda, which will be Anya presenting the June 2021 financials.
Good afternoon, everybody. Can you hear me okay? Okay. All right, so first we're going to go through June financials, which were in your packet. So we'll walk through the monthly trend charts that you typically get. So if you can move to the next slide. Yep, that one. Thanks. I don't know who's, it's Suzanne. Okay, that way I know who I'm talking to. Okay. So revenue for June is actually looks a little different than prior months because when we look at this chart, we do this to show you what it looked like last year compared to this year. And so the reason you see that last year blue line going across that peaked in June of last fiscal year was just because that was when we were starting to get caught up with everything. We were starting to get the enhanced payments from MDHHS for direct care staff. So it's not that it's really gone down much, but what you're just seeing is last fiscal year, we had some spikes in payments as well. We're still well over what we would have been getting had it not been a year full of pandemic. You can see that the eligibility trend that we'll see on the next chart, if you want to swap to the next one, is still quite a bit higher than last fiscal year. So that really tells you that's really where the revenue is coming from, is the eligibility trend. It's not just that we're having those spikes in payments that would indicate the rates being different. It's really that the eligibility trend is still quite a bit higher. And so we've been seeing that consistently throughout this fiscal year. As we're starting to plan for fiscal year 22, we are planning for that to start to trickle down a bit, assuming the pandemic gets better. We'll start to see people coming off of some of the Healthy Michigan eligibility, as well as the, it's not auto renewal, but it's the redetermination process. Supposedly is no longer going to be paused as of, I believe, September, could be December. I have to check that date to make sure. But right now, throughout the entire pandemic, if you had Medicaid, you can't come off of it. That will end at some point. And so what will happen then is we'll just have to make sure we're really keeping an eye on the eligibility trend and making sure that people that are coming off or falling off of Medicaid are encouraged to reapply and make sure that they have access to the documentation and everything they need to stay on Medicaid eligibility. Next slide, please. Okay, so this is assets. So this looks at September of 2020 versus now. So you can see our cash and investments is up quite a bit. That's primarily due to the increased revenue we've had this fiscal year. Receivables is down, but again, remember September 30th is the end of our fiscal year. So we would have booked receivables that we expected to get for fiscal year 20, and then by now we've collected some of those. So that's kind of a revolving amount that tends to be a bit higher at year end, but throughout the year it does go down just as we collect the things that are outstanding. Other assets is a minimal amount and doesn't change terribly, and then capital assets being things like buildings and long-term investments just goes down slightly over time due to depreciation. So what you're now looking at is liabilities. So again, as I mentioned, at the end of the fiscal year, liabilities typically are much higher because we book everything that we have due to providers, which is really just a timing issue. But at this point in the year, we're just wrapping up third quarter, so you can see they're down quite a bit from the end of the fiscal year. Due to state is roughly the same, and that's just an accrual of the amounts that we pay to them on a monthly or quarterly basis. Employee payables, again, is a minimal amount and doesn't fluctuate terribly. And then long-term debt, again, reduces monthly related to payments on the Resource and Crisis Center lease and things like that. So what that looks like as it relates to net position compared to the end of last fiscal year is our net position is up a bit. And total assets are up a bit, total liabilities are down, which means our net position has increased quite significantly. So that's a good thing. It's rare that the finance person has good news, so that's where we're at as of the end of June. Okay, so now if we're looking at specifically revenue year over year, so this is looking at revenue last fiscal year compared to revenue this fiscal year in the same time periods. So you can see what I mentioned, the revenue is up significantly from last fiscal year. From a Medicaid perspective, general fund is roughly the same, just slightly lower. County funds is exactly the same. And then all other is just slightly lower because that includes things like grants and that have since expired. This one looks at the same way, whereas it's year over year. So administration is down. Provider network expenses are up, but we would expect that based on the pandemic and the enhanced compensation that's been pushed through to the network. Grants are down a little bit, but as I mentioned, some did expire compared to last fiscal year, and then all other is roughly the same. So what that means from a net income comparison, this period last year versus this year, is our total revenue is up. Total expenses are just slightly above where they were last fiscal year, so our net income is up. This is the list of the top 15 providers and the amounts that they were paid this month. In addition to that, you also had in your packet, and I do not intend to go through it, but that list of all providers and their year-to-date payment amounts. With that, I will take any questions.
Sarah Melchiah has her hand up.
Thank you, Melchiah. Thanks, Jonathan, because I cannot see with the small screen.
I just want to know, Anya, if you could give us, not right now, but could you tell us what we would possibly look like if the bills went through? If they take away the PIHPs, what will we look like? If they do away with the whole system, what would we look like?
So to be honest, I would love to be able to do that. However, because I don't really know what that structure would look like, it would depend on if we still existed as a CMH and money were to flow through us as a CMH and just the PIHP or that administrative function were to go away, and if and how they were to handle that. So as a PIHP, technically, we're the managed care organization for all of the CMH services, but our SUD revenue and service obligations run through the PIHP contract. So It's a bit commingled, and so it would really depend on how they operationalize those plans. So I don't personally think, and Ben could certainly probably tell me I'm wrong, but I don't think they've operationalized it yet. I think it's conceptual right now, but they're going to have to sort all that out.
Right.
So I really have no idea, because as a PIHP, those would cease to exist, or there would be one, or however they would work it. I don't know from a CMH perspective what that means if money still flows through a CMH, and that would mean if you're a CMH that provides direct services, which we are not currently.
Right.
So again, it really would depend on how they rolled it out and what we as an organization look like at that point.
Okay, thank you.
So that was a lot of a not answer. I apologize.
Anya, so I have one question. I know that at our study session at the end of this month, we're going to be looking at the upcoming 2022 fiscal year. And I know we're 3 months behind in terms of what we're looking at now in terms of dollars. Have you heard anything from the state about where they're at with their budget that may impact our budget?
So I have seen draft rates. We have them, and we've used them to project potential rates for fiscal year 22. It wouldn't be the first time I've seen them change them from draft rates to final rates. Also, right now, as Ben mentioned, the enhanced wages is not currently included, so we've projected without that in there. So obviously, that's going to play into this. We'll be updating that document until probably the day that I present it to you guys, to take every bit of information we have and try to project what we think might happen. But that's really why I end up doing a budget amendment in the first quarter, because it's really our best guess based on historical information, revenue, eligibility trends, and all of that kind of stuff. So the draft rates I saw don't look bad. If that also included that enhanced compensation for direct care workers, obviously that would be amazing to be able to include that and make that permanent. But right now, until I see final ones, they're just what we were told as draft estimates, and so that's what we use for now. Because right now the structure is all set up, we have the gist of what we think it might look like, and we'll go back and tweak that for up until you guys approve it.
So those rates are slightly higher?
Yeah,
going
so what really changed is some of the historical way they do those factors that play into how our rates work. So they took the last fiscal year's data and then updated it based on the individual needs, the diagnosis information, all those different factors that play into the actuarial method. Ours resulted in us getting a bit of an increase related to those things, and so we get an area factor, for lack of a better way to call it, for each of those factors, and so the combination of all those then results in our overall factor for Oakland County. So that did bump us up a little bit, but again, what I saw is just draft, so they could change that.
So that's looking pretty good then, assuming that's not gonna, they change their minds. The number of persons in Oakland County that are under Medicaid, any of the programs, is up, so that means we're gonna have solid revenue, at least for the first quarter.
Right. So what we ended up doing with, we kind of project bookends, and then we kind of find a happy medium. So we project the bookend first of, all right, if eligibility stays exactly the same as it is right now. And then we would project, okay, if eligibility went back to 2018, when we were at our lowest point, what would that look like? And then we looked at it and we said, okay, what do we think is really realistic for fiscal year 22? And from my perspective, and a lot of it, I think it's not really, you can't predict it because we don't know what's going to happen with the pandemic and all of that stuff. So our best guess at this point is we'll start to see a downturn a little bit. So what we did was take this fiscal year and last fiscal year and kind of combine them to project kind of it being high but starting to trickle off a little bit. To be on the safe side, I always budget conservatively. I've told Dana this multiple times. I'd rather come tell you we have more money than that we have less. It's easier to find ways to push money out than it is to cut things back when things are rolling. So we tend to err on the side of conservative when it comes to revenue and high when it comes to expenses. So the number we're at right now, I'm fairly comfortable with if the rates stay where they're at. If those change, obviously my numbers will change.
Okay. So my last question, and then I'll turn it back over to Sarah, is because I'll drag myself back into our current where we're at with June, rather than looking into next year. I've noticed that it looks like our number of services or our expenses are starting to grow up as we're doing more services to the field, or our direct providers are providing more service to the field. But you've also said that in the past we annualize and amortize in 12 monthly increments the services cost to our providers. I probably just said it backwards.
That's okay. I'll try to restate what I think you said, and then so in a normal year, we would be utilizing our service models, which that way people get paid for the number of individuals they're serving and the frequency in which they're serving them.
Right.
And so what we would do is look at those dashboards each month and make estimates on what we think those months are going to be, and we would reconcile those quarterly. In a pandemic year, all bets are off. So what we did instead, because we're in a pandemic, and actually some of our providers are back on service models. Adults serving people with mental illnesses have been all year. But other providers, because the volume is different, significantly different than what we had built service models on, we had to move back to what we call a cost reimbursed contract, which is essentially how we used to fund them. Meaning, as long as the Medicaid costs are reasonable, allowable, and appropriate, we reimburse them. And so right now, during this, I'll use vocational as an example. Their capacity is nowhere near what it would be normally. So funding them on a service model built on a specific capacity, they would not be able to make ends meet. And so part of our job as the managed care organization is to have a network. And so we have to find ways to fund them in this time to keep them sustainable so that they're there when we get out of this. So that's why we moved to a cost reimbursed contract, because that still allows them to get cash flow in to make sure, but it still puts the burden on them that they have to be Medicaid allowable, appropriate, and reasonable. And we go back and test that stuff. The audits go out and test providers. We go out and test providers. So there's lots of double checking and all of that kind of stuff, but it's a way to fund them in a crisis situation that really takes it so it's not, I don't want them worrying about cash flow right now. I don't want them trying to make sure that they have money to pay direct care staff, because obviously we're struggling with direct care staff. So this mechanism of doing it is an easier way for everybody involved. It takes more work for my staff to reconcile that stuff and keep track of it all, but I think from a network perspective, I think it was the best choice for the situation.
All right, I had one more question. I'm
Hey, I
sorry.
got all kinds of information.
All right, because Ben mentioned it earlier too, about we're the only CMH or PIHP that does outcomes measures and
Mhm.
bonuses. Are we looking at doing more of those for the rest of this year and moving into next year? Are we making a return to those, I guess?
Yes. So adults with mental illness, those providers went back at the beginning of the fiscal year because their volume was such that they can sustain it still. We're taking each other network quarter by quarter and saying, okay, are we in a situation where you're back to normal capacity? Residential providers, obviously, we have the staffing crisis that is exacerbating that situation drastically. ABA providers are still, autism providers are still not to the capacity where they would be sustainable on the service models, vocational providers being another one. The goal is to get everybody back as fast as possible because that's really more along the lines of our values. However, we want to not make this a time when they have to try to function in those environments. However, we're still looking at all of those things. We're still looking at how they're doing on those outcome measures, how they're doing on all of those things, and still expect them to be working at those service delivery priorities, but it doesn't mean we're necessarily funding them on the service model that we had designed.
Thank you.
Yep.
Back to Sarah.
All right, I'm actually gonna turn it back to Anya, but before I do so, we just wanted to make sure that everyone who's not speaking has their mic turned off because there is some feedback that we're getting, as well as if you're virtually to making sure that you're muted, please. And Anya, I will turn it back to you for budget amendment number 3, please.
Okay, I'm going to give Suzanne a quick second because she's fighting with the PowerPoint. But you all have your budget amendment number 3 in your packet, and so, as mentioned, we do budget amendments usually at least 3 times a year just to keep things up to date with changes happening within revenue, within expenses. And so the budget amendment you have in front of you will be our final amendment for the fiscal year. And so I'll walk you through, this is the standard setup. Suzanne, you can go ahead and hop to that first slide, please. So this is the typical way we will present this to you, and what you're looking at on the left, obviously, is the budget categories and how the budget is set up. And then that first green column there is the last budget amendment you all approved. So that's the number that's already approved in the budget. The next middle column is what changed between that amendment and the one that we're doing right now that I will be asking for approval next week for. So I'll walk you through what actually changed in each of those sections, and then I'm probably going to pause just to let you ask questions if you have any in between the sections, just so that everybody has a chance if you have questions. So looking at this first section here, Medicaid revenue, you can see Medicaid revenue, we had budgeted about $282 million. We're seeing that come down just slightly, so we're moving that down to about by about $3 million, putting us at about $278 million. So again, that eligibility trend is going to start to come into play here. At some point, we will start to see things change a bit, and this is more likely related to us projecting it going up at a different rate than we actually saw it going up. This is minimal comparative to the entire Medicaid revenue amount, but we do like to keep it as close as possible in the budget just so that it's an accurate reflection of what we've received. Medicaid waiver is specifically children's waiver funding, and so that one is going up just slightly. And then Healthy Michigan is the real big change here. And so Healthy Michigan is actually where we saw the biggest increase percentage-wise for eligibility. It's just that our payment for Healthy Michigan is just under $100, where our payment for the specialty services is over $300. So we had more people come on to Healthy Michigan than we did in 2014 when this started. I think we're now at about 65,000, and that's the highest it's been. I'm sorry, not 65,000, 650,000, I believe is what it is across Michigan off the top of my head. So that revenue is up quite a bit, up $7 million. So you're looking at roughly $49 million. And back when we started this, the first year, I think it was $14 million. So definitely a big swing. It has been going up, obviously, throughout the last 18 months. And that's the one we'll see drop the quickest too. People get presumptive eligibility for Healthy Michigan. So if they don't renew it and they don't end up on full Medicaid, then this one will drop off. Any questions on revenue before I move on to, on Medicaid revenue specifically before I move on to state revenue?
Anya, I know initially when they started the Healthy Michigan, it was an issue with people being eligible for full Medicaid, but because of the difference in applications, they were moved into Healthy Michigan. Is that still an issue?
So personally, I think it's still an issue because it's easier to qualify for Healthy Michigan. You don't need as much paperwork. You don't have to document your assets. It's easier. We have put some incentives in place with providers to get people from Healthy Michigan to full Medicaid, again, because of that difference. For them, the benefit array is no different. For us, it's a pretty big difference in payment. So it's important to us that they get it and to make sure that they're getting as much as we can for each individual. Again, that presumptive eligibility, if no one follows up with them, you wouldn't necessarily know that you could be on full Medicaid because you've got to turn in all the paperwork, but you might get it up front for a year or however many months presumptive eligibility allows. So that's always something we watch, especially people that were on full Medicaid and then dropped to Healthy Michigan. So we do keep an eye on that. Yep. I don't see anybody else, so I can move on to state revenue, which you can see didn't change at all between Budget Amendment 2 and 3. And so moving to other revenue, the other revenue grant has gone up by about $235,000, and what that is from is an SUD peer respite grant. So that is a new grant we will be implementing, and as well as a PPE grant for SUD providers as well. So those two things were just recently added. The peer respite grant is not just for this fiscal year, I believe it's also for next fiscal year as well. Dana's shaking her head, so I think I'm right. SUD other, that's just a slight adjustment in revenue down. So SUD other is typically PA2 funds. So it's coming in a little lower than we had budgeted. That's not surprising at all, just because PA2 funds is convention and liquor tax. So with no conventions, you'd see less convention tax. The other one, so that's a net of about $150,000 increase for a total increase in revenue of about $4.8 million.
Question, what is the source of that grant? Is that coming
The source
from the
of
state?
that grant, that's a good question. It's an SUD grant. I believe it's a block grant off the top of my head.
I'm sorry, I don't recall. We would have to look. I can't remember.
Yeah,
No.
no, I believe it's a state grant.
It's a state.
Yeah.
Okay.
I just want to know if we could get more information about that specific grant,
Yep.
please.
No problem.
And just add on to that, anytime it's a peer program, I personally would be interested in having more detail about that.
Okay, no problem. Okay. Suzanne, can you jump to the next slide for me? Okay. So this is the bottom half of the budget you would typically see. And this, again, same structure, same setup, so I'll walk you through the changes that are outlined here. The autism provider expenses are down a bit, which, again, is not surprising related to during the pandemic. But what is primarily going on here is when we bid out autism services, there was a leftover contract that our providers had with a particular organization. And the goal was to move those individuals out of that organization as our other providers were able to take them. That's a slow process, but it is happening. So that's what you see happening here. That provider that they were with is funded on a fee-for-service basis, and their rates are much higher, which is part of the reason we didn't end up contracting with them. So this is what you see happening here is those individuals moving to one of our contracted ABA providers, therefore reducing the expense.
A being autism.
Yes, autism, I'm sorry. It says I need to just change that acronym up there to autism so that I don't say ABA. Okay, core provider adults. That one is specifically, and I have my notes in front of me here. So core provider adults is up by about 1.8 million, and that's primarily due to an increase in service, the number of services, and the number of people being served in the adult system. So we are, as I mentioned, the adult system is actually back on service models because capacity and volume-wise, they actually are serving more people than they were prior to the pandemic. So we are adding just under $2 million because they are serving more individuals, 1.3 of that being in the IDD service network and the remainder being in the MI adult service network. Crisis and acute care services, you see that increase of just under 2.5 million. That's really because hospitalizations are up. The costs are up and the number of hospitalizations has gone up, not surprising during the pandemic. And in addition to that, anytime the hospitalization expense goes up, so does the matching HRA payment that we are a pass-through for. So the state, anytime we pay a hospital for a day, the state also pays us an additional $309 to pass on in addition to our daily rate. So they're tied together. So we definitely are seeing an increase in hospitalizations. Moving down to substance use, bear with me, I'm trying to read it from up there and I should not be doing that. Moving down to substance use, that 116,000 increase is the SUD SOAR grant, and so we got additional SOAR grant funding, and so this is the expense to match that. Grants, we will always budget revenue the same as expense because they're intended to be a wash unless for some reason they don't allow administrative costs or something like that. But it was an increase to the SOAR grant. The next grant line is specific to that SUD grant that I mentioned earlier related to peer respite and the PPE grant for the SUD network as well. Claims and use tax, so that's a percentage of revenue. So we had that just slightly over budgeted prior to this, and so that's just us cleaning that up prior to the end of the fiscal year, that we will not be paying that amount in claims and use tax. In addition to that, the local match drawdown expense has been reduced as well. There has been a push to try to reduce or eliminate that requirement altogether. I do not believe that was addressed in what we've seen of this year's upcoming budget, but this was the slight attempt we had at it in fiscal year 21. So what that amounts to is an increase in expenses of just over $3 million. So that netted against the increase in revenue, primarily from Healthy Michigan, leaves us a change in net assets of an increase to about $1.9 million, so just under $2 million. So I'll pause real quick for questions before we talk about fund sources.
The SOAR grant is?
Oh, geez. It's a substance use grant. What it stands for is another question. I can find out and tell you. I can't remember off the top of my head.
Hadass had her hand up, Anya.
Okay.
Okay, so hi, thank you. This is really helpful. I had a question about the core provider adults, about the 1.8 million. So you said 1.3 was for IDD, and then obviously the other 5 is for just the general population. It seems, did we just estimate wrong, or is that really more like post-COVID? Like, I mean, it makes sense that there would be a need for more services. I just kind of want to talk a little bit about, that's double IDD versus the regular population.
Yep. So roughly 644,000 is an increase to people receiving targeted case management, and that was both an increase in the number of individuals served and the amount of services they are receiving. The 1.3 increase for IDD was specifically related to the number of individuals being served. And then finally, a $150,000 decrease for those being served in the ACT team. So that would be MI adults receiving ACT services. So what you're
Can you
looking at
remind me
there,
what that ACT is? I forgot.
assertive community treatment. It's a level of care that's higher than targeted case management, more intensive outpatient services, not quite just below what you would consider residential level services.
And that got decreased?
ACT, yes. That's a utilization decrease that caused that. So we are serving less people in ACT than we were than we had budgeted.
Okay. So maybe not for now, but another time, it would be interesting to know, like that's the cost, but the number of people actually that were added. We don't need to know right now, but just to be, just to have an understanding of how many people more that we obviously didn't have last year and we didn't anticipate, if you could let us know. But that's not your responsibility, really. Your responsibility is the numbers. So thank you for your answers.
We'll follow up.
Great.
Okay, I don't want to jump ahead without, if there are more questions. I can't actually see well enough to see if there are hands up, so bear with me.
I think
there's
we're
no
good.
There's no more here. How about online?
Nope, we're good online, so I think we're
Okay.
good to move forward.
So this is the fund source document, which just gives you an idea from a fund source perspective, kind of where we're landing right now and where budget amendment number 3 will put us. So this top category is all Medicaid related funds. So both revenue on that top row and expense on that bottom row. The middle row, and the bottom row there is surplus and or deficit. So what you can see is we're projecting to have a roughly $13.6 million surplus in Medicaid. So you've heard me say before, my goal is to be able to put some money back in the ISF. We spent a large chunk of it in fiscal year 18 and 19, and I would like to be able to put that back in there at the end of this fiscal year. The next section you're looking at is kind of other miscellaneous, which would be general fund, local grants, and then non-MDHHS. So if you look at general fund, we are still slightly overspent on general fund by about $800,000, but we do have those local funds to help make up that loss. We still will have a local surplus of about $2.9 million. And so that we will be able to carry forward into future years. The next section being SUD specific, PA2 funds is a surplus of about $3.6 million. You can see that we do have a deficit in block grant, but that was an intentional deficit in that we had a planned block grant budget, and we got cuts to our block grant, I believe it was in November or December, so after the fiscal year started. And we chose to use PA2 money to cover that instead of reducing services or cutting rates. That being said, we will still have a surplus of PA2 of about $2.2 million for a total surplus of about $18.9 million. So that, in a nutshell, is BA3. This will come to the board next week for approval. So if you have any other questions, feel free to let me know.
All right. Thank you, Anya. We appreciate everything. Oh, I see in the chat, the SOR state opioid response grant? I think we addressed that, but all right. We will move on to our quarterly report from our quality and regulatory compliance. So I had Wendy Schiller. Is Wendy presenting, or is that you?
It
Marky,
will
I see you on
be
there.
Wendy and I
Well.
both.
Oh, I can't hear you though. So, oh, there we go. Oh, perfect. Okay. Well, thank you.
Okay, can you hear me?
Yep, I can hear you now. Thank you.
Okay, good evening, everyone. Wendy and I are here tonight to present to you our quarterly report. We can move on to the next slide. This is just a graphic of our team makeup, and you've seen this before, so we can move past that. This slide just highlights some of the responsibility and deliverables that our team has. We've also reviewed this previously, so we don't have to spend a lot of time on that. We can move to the next slide. So what we're going to be talking about tonight is our status on the annual plan goal item that pertains to meeting MDHHS contract requirements. We're going to be talking about two different sets of performance indicators. I'm going to be speaking about the PBI, which is the performance bonus incentive measure, and then Wendy's going to be speaking about our quarterly performance indicators. So the performance-based bonus incentive that the department has identified for PIHPs to work on jointly with the health plans is there are several, but the one I'm going to be speaking about tonight is the short name is IET. This is a HEDIS measure, and what IET stands for is the initiation and engagement and treatment of alcohol and other drug dependence. The work in FY21 focused on looking at our data, ensuring that the data was valid and accurate. There's a bit of a hurdle with any of the AOD measures due to confidentiality requirements. So I'll talk a little bit about that more a little later on in the presentation. So for FY21, it was just an informational measure. There were no bonus dollars tied to it. In FY22, there will be bonus dollars tied to this measure for specifically for reducing racial disparity. The language that we had in our contract for FY21 is here. They compared performance in calendar year 19 to the 12-month time frame of July 2020 through June 30th of 2021. We can move to the next slide, please. So this is a description of what the IET measure actually tracks. It looks at persons that are new to service, so persons that have not received service in the past 60 days. It basically looks at two different time points of measuring essentially a follow-up contact visit. It looks at the contact of a follow-up visit 14 days after the initiation of an alcohol and other drug diagnoses. And then it also looks at the visits at the 34-day time point. It's looking for an additional two appointments that have occurred following the initial initiation visit. So there are two different time points that are included in this measure. In order to get the incentive, a PIHP will have to meet both the 14-day rate and the 34-day rate. We can move to the next slide. So the department has set some benchmarks that the health plans and the PIHPs are to meet with this measure. For the IET 14 rate, the benchmark is 42.5%. And for the IET 34, the target rate is 18.5%. So with that said, the expectation is that the overall percentage for the populations that are being measured for this indicator, you are expected to meet these benchmarks, 42.5% and 18.5% for the IET measure. So the intent behind this is to decrease the disparity between the index population and at least one minority group. The index population is defined as the white population, and we can move to the next slide. The index population is defined as the white population, and you can see on this slide several different minority groups that basically you can see here the contact rate for the IET 14 rate. The index population nearly met the 42.5% benchmark. And you can see from this slide for the time period of calendar year 18 in comparison to calendar year 19, the African American race had the largest amount of disparity from in comparison to the index group. We can move to the next slide. This is the slide that shows information on the IET 34 rate, looking at statistics from calendar year 18 in comparison to calendar year 19. The benchmark for this is the 18.5% rate. The index population, the white population, met that benchmark at that time. For this rate for 2019, it was 19.19%. In comparison to 2019, for the African American Black race, the rate was 12.07%. So there's a bit of disparity there statewide. We can move to the next slide. This slide shows performance rates across all the PIHPs. The highlighted areas show the highest performing PIHP and then the lowest performing PIHP. And you can see Oakland, we're the third PIHP over from the right. Our rate for the IET, overall rate for the IET 14 in calendar year 19 was 39.3%. Can move to the next slide. And this is the data for the IET 34 rate. The highlighted areas are the highest performing PIHP and then the lowest performing PIHP. And then again, Oakland is all the way over to the right, the third one over. Our performance rate overall was 16.89%. And we can move to the next slide. So this gets into more current performance data. The graph on the right has performance data on the IET 14 rate. The data that's shown here is performance data for calendar year 19 in comparison to performance data from July of 2020 through June of 2021. The performance rate for the white population was 43.58%, and for the African American population, the rate was 34.56%. The IET 34 rate was for calendar year 19. You can see the performance rates for both the white and the African American races. The disparity decreased. It increased actually for the African American race when you look at calendar year 19 in comparison to the time frame of July 2020 to July 21. And you can also see that that it also decreased for the white race during those two comparison time points. So let's move to the next slide. So what are we doing to be able to show that we're making moving the needle along with this? We have to be sure that our logic is matching the same logic that the state is using to report out on these outcomes, and we're working on that, getting close to matching out the data so that we can really look at our performance lifetime. The concern is with the substance use data is that that data is not in Care Connect 360 due to confidentiality requirements. So we don't have immediate access to that data. The state has to download and send us a file. So it's really hard for us to be able to impact this, but our performance does show that we're doing okay. We're close to meeting the benchmarks, but we still have some work to do. I know that the department is working on looking at being able to provide. I've heard that the department is looking at being able to provide us access to more real-time data for the SUD population in Care Connect 360. But even with those barriers that we are facing, we are our nurse care managers. We have monthly meetings with the Medicaid health plan staff. Quality staff have recently began to attend those meetings with the nurses as well to kind of talk with the health plans to see what they are doing in terms of improving performance. One of the major barriers is if you don't have a release on file, we can really only impact people that are known to us where we already do have a release on file. So we are having discussions with the health plans about being able to starting to use the standard consent form to really get the release from the individual to be able to share information so we can coordinate care. We recently have gained access through Care Connect 360 for the admission, discharge, and transfer data. That data is useful for another measure that the department is looking for shared performance between the PIHPs and the health plans, and that pertains to follow up after hospitalization for persons that have been hospitalized, been in treatment for alcohol and other drugs. There is also shared shared care plans that OCHN has with the Medicaid health plans. So with those shared care plans, the nurse case managers are meeting with the health plans monthly to be able to jointly work on improving coordination of care for those individuals. So it is likely that some individuals that would fall into the performance measure of IET would fall into this category as well. The MyHIN has also recently been working with e-consents. There is a pilot in place to begin to utilize the issuing of electronic consents for SUD providers. So we are starting small with piloting it with one provider right now. That will certainly help with improving with this effort because if there's a consent on file, we're able to do coordination and not have to worry about that barrier of confidentiality. In terms of other shared metrics that the department has the PIHPs focusing on with the health plans, we have the FUH HEDIS measure. That HEDIS measure pertains to follow up within 30 days for an inpatient hospitalization for mental illness. I already mentioned the FUA measure, which is follow-up after an AOD hospitalization. And there is also the IET, which is what we were speaking about in this presentation. So that's where we are as of today. I'm hopeful that we will be able to make some strides in terms of getting the real-time information in Care Connect 360, so we can continue to move the needle a little more towards the benchmark with this. So I will pause for questions here before Wendy gets into the performance indicator presentation.
Wait, are there any questions? I don't see any hands up virtually. Anyone in person have any questions?
This is Vijaya. I have a question. Could you please explain the difference between IAT 14 and 34? And also, if we could get a periodic update as to what is our progress on fulfilling these gaps that seems like is lack of access to information or data.
Yes, we can definitely do that. The IET 14 is the follow-up visit 14 days after the initiation of, after the identification of an SUD diagnosis. The IET 34 is the two follow-up visits within 34 days of the initial identification of an SUD diagnosis. So there are two different measures, and in order to earn the incentive, we have to show that there's been a decrease in disparity for the index population and the minority population for both those, both the IET 14 and the IET 34.
Thank you.
Marquita, I have a question. It's Jonathan. Are these visits or these treatments, are they just inpatient, or can they be ambulatory outpatient visits as well?
They can be ambulatory outpatients. They have to be for an AOD diagnosis. It can be telehealth. It can be Medicaid assisted treatment. It can be an intensive outpatient visit. So there's a wide variety of CPT codes that apply to meet this measure.
So then, since it's challenging to get the data because of PHI and confidentiality and getting the data from ADT messages, if you will, from that MyHIN thing, the data exchange, is it possible to track it just on our ODIN system with service providers we have?
Yes, and part of our work that was done this year was the department wanted all the PHPs to do some data integrity efforts just to see how well our rates were. And I don't have it committed to memory, but I do remember that we did pretty well with persons that were known to us. Persons that were not known to us, um, then we don't have a release on file, so we didn't do as well.
Right, but we know more of our people than those we don't know. So I'm just
Yes,
hoping that we're able to harvest the data, at least from the ODIN system, from the data network.
absolutely. The issue is still, we have to have that real time data to really be able to follow up timely.
Malkai has a question.
Marquita, just for clarification, they're saying that both the index population and the at-risk populations have to have a decrease in the numbers in order for the incentive to be paid?
No, we have to show, our data would have to show that there's been a decrease in disparity between the white population and the African American population. So basically, we would have to show that we're doing a better job at getting the minority group to get those appointments at the 14-day point and again at the 34-day point. So if as long as we're focusing and working on that, we would be decreasing disparity, which would
In
meet the
both,
measure.
in both the Medicaid health plan, and we would receive a payout, the
Um,
incentive?
The incentive payments are separate for the health plans and the PIHPs. So we would
Okay.
get a payment, and then the health plan, they have a population that they're focusing on as well.
Thank you.
This is Vijay. I have one more question. What is the ratio of the recipients that are in our system inOrden versus out ofOrden?
That is a good question. For this specific measure, I can include
Yes.
that in a future update.
Okay, thank you.
Okay, I believe if there aren't any more questions, we can move to the performance indicator section.
Okay. Good evening, everyone. One of the ongoing goals that the Quality Improvement Department has is, of course, to meet compliance with the MDHHS performance indicators. So I'm going to give an update on the data for the quarter ending March 31st, which is quarter 2. And I'm glad to report that we met all of the established standards for quarter 2 for all of the indicators. So during this presentation, I'll give some updates on indicator 1, which is some of the quality improvement efforts that Common Ground has been working on. We still do not have an established standard set by the state for indicator 2 and 3. This is still considered the baseline year for these standards. And I'll also be reporting on a new standard, which is our expired request that is looking at any approved requests for SUD services that didn't result in an actual admission within 60 days. So next slide, please. Okay, this first graph is our first performance indicator. It looks at the percent of dispositions that were completed within 180 minutes. So this is a measure that measures the work that Common Ground is doing for inpatient screenings. The standard that was established is 95%. So I think we talked last time about in quarter 3, we had fallen below the standard for a couple quarters. So we started to implement some quality improvement efforts with Common Ground, and we had several meetings with them to talk about how we can bring these rates back into compliance. So they currently are still sending us weekly updates on a review of all cases that are over 180 minutes. So they will send us a summary of their findings for the case and any items that they can correct due to data entry errors. They've been correcting those. So some of the cases that were out of compliance were really due to some process issues. For example, if a welcome form was not documented in the correct procedure of the process, the start time for the indicator was not correct. So it would pull from old welcome forms, which may have been months prior. So once we worked out some of these process issues and they did this more regular review, we can see that this really resulted in some real improvements in this area. So they have been in compliance for the last few quarters. Next slide, please. So performance indicator 2A looks at the percent of intakes that are completed within 14 days of the non-emergent request for services. So this is one of the indicators where the state is just collecting baseline data information from all the PIHPs. So as you can see, and I think we have discussed this as well previously, in quarter 3 of last year, the state made a lot of changes and they removed any exceptions from the indicator for number 2 and 3. So prior to that, we had been performing very well in this area. And the most common exception would be, an example would be if somebody was scheduled to come in for an appointment and didn't show. So we used to be able to remove those from our denominator, which would, impact the score. And so since we cannot, the scores went down, of course. So they're just collecting data at this point, and hopefully in the next quarter or two, we'll start to hear things about what the new baseline, what the new goal will be set at. So these are just the results of the 4 different populations that we report to the state. Next slide, please. Indicator 2E is the expired request that I mentioned before. And at this point, we're just the state wants us to report just this number of expired requests for each quarter. So I don't know if they're going to set a new indicator related to this. They again are just collecting to set some baselines for future goals. So these are the number of people that had approved requests for services that did not have an admission within the 60 days. Next slide, please. Performance indicator 3 measures the percent of first services that are completed within 14 days of the intake. So this is another one where we no longer have exceptions removed and there is no standard set yet. So we continue to do well on this measure. The reason being that most of the first services would be done on the same day as the intake, the way we've set up our processes. So the person would have an intake and then likely have a pre-plan done right at that same visit on the same day. So this slide is just showing the children's populations and the results there. And then if you move forward to the next slide, you will see the adults. And again, the lowest rate we've had is Q4, we had 99%. So again, we have very high rates at this indicator. Next slide, please. Okay, indicators 4A and B are related to continuity of care. So the standard is set for both of these at 95%. These indicators still do have exceptions. So anybody that was scheduled for a service that did not show, or somebody that may have declined services, we can remove those cases from the denominator. So 4A relates to a follow-up visit after a hospital discharge within 7 days. So as you can see, we've done very well in this area. And 4B is looking at people that were in SUD detox services that they were seen for follow-up within 7 days of discharge from that service. So again, we have very high rates here. For this indicator, it's pretty common that someone would be in detox services and then transition to residential perhaps, and many times that's at the same facility. So we do see a good transition rate from one level of care to another in this case. Next slide, please. And the final indicator is inpatient recidivism, measuring the percentage of individuals that are readmitted to the hospital within 30 days of their initial discharge. So the goal is set at below 15%. So as you can see, we have met and exceeded this standard. Our providers do very well with this indicator. So are there any questions about performance indicators?
Okay.
You probably told us before when you brought it up about the state disallowing the exceptions, but what reason did they give for those disallowing those exceptions? The no-shows and things.
Yeah, I don't know if Marquita may recall more detail about that. I think they may have been given feedback even from CMS or someone that, we really need to look at, all of these cases and not be removing a lot of cases, but I'm not sure about that. Do you recall anything
Okay.
about that, Marquita, specifically?
Yes, Wendy, you're
Okay.
correct. That was exactly why CMS had said, well, you guys, you've been at 95, 100% consistently because you can remove these exceptions. So that was disallowed.
Mhm. Yeah.
So
Any
this
other?
is Vijaya. What, why are there no shows? Are there some process of reminders, or is it the time lag that people forget that they have to complete that process? Why does that happen?
Yeah, I mean, there's probably a lot of reasons that that may happen. I know providers do have written procedures about outreach. So if somebody, they try to remind them about appointments. If they don't show to their appointment, they try to call them that day to reschedule, so we try to have processes in place to catch that. I mean, yeah, it could just depends on the person. Someone getting out of the hospital may I mean, I don't really know.
I would think this would be very important for outcomes. I mean, it's like you are desperately seeking help and then suddenly
Hmm.
something happens. So, I mean, there has to be some reason for that.
If I may chime in,
Yes.
we are collecting that data, I believe. We um, need to be able to look at that and analyze it. One of the most common reasons is that folks reschedule. And I mean, that happens all the time. That was previously an allowed exception. That is no longer allowed if the reschedule falls outside of the 14 days.
I think something like that would make good sense that either people are not able to come to the appointment or other issues. I mean, there could be a number of issues that they can't make up that follow-up appointment. So, thank you.
So I just want to, it's Jonathan. I know on the healthcare side, some of the physical healthcare folks have run into the same thing with follow-up days after discharge for any kind of inpatient service. And so they have focused teams to focus on the, reaching out to those patients while they're still there or on their way out during the discharge process, so that they're engaged in day 1, day 2, day 3, so that they make sure that they make that 14-day, or at least for our case, it's a 14-day visit. I think for theirs, it's within 7 days seeing a doctor for follow-up care. So that's why they're all on top of it for the same kind of measure. So perhaps that's something we can do to support our direct providers. I don't know. Malkaya, you're about to.
I just wanted to add, transportation is a barrier. Now, the health plans can provide transportation,
They do.
and not all of our providers provide transportation. So that's a huge barrier.
And they still come up short, too.
We also try to encourage providers to make appointments for day of discharge. So that way they're going straight from the hospital or whatever setting they're going to directly to their outpatient provider. And that's been very successful in trying to do that in terms of texting and calling, and those things also work. It's a number of different things. But I think one of the things I think we need to return to is really introducing that outpatient provider to the person who is leaving the hospital before they leave the hospital. That's another thing that used to occur that was really successful, so that when they actually went to their outpatient provider, they were very familiar with who they were going to be working with. So those are the kind of things that used to occur and sort of fell off and now need to come back, because now we're measuring it better, like Marquita and Wendy are saying, is that we're not allowed to use those exceptions anymore and sort of change the outcome. The outcome is what it is. Now we need to look at the reasons why it's occurring and put those things in place to make sure that people get to where they need to be.
I think
There any other
discharge planning is very, very important. That's not always taking place either. If you could start the process earlier, before the person, engage a person at least a week before the discharge, so that they know this is the agency you're going to, this is your case manager, all those things help.
But I find that in most instances, discharge planning is started, and I've heard from in the previous sessions from the leadership here that discharge planning starts within 24 hours. So that is there. It's probably the support that the people need are not there, like you mentioned, transportation, and I agree that's a big issue. So I get that. Now it kind of, that means one piece of the puzzle is there. Thank you. Thank you.
Okay. If there are no other questions, then that concludes our presentation. Thank you.
Thank you, guys.
Thank you both for your very informative presentations. That was very helpful. All right, we'll move on to other business with the CEO update with Dana.
I just had a few very brief things. One, I wanted to be thankful for Ben Boykin coming from Capital Services to give us the legislative update, but also just to add, there is a town hall meeting that's occurring next week, I do believe. I don't have the exact date and time in front of me, with Mary Wyford. And I really encourage you all to attend if you can. I know there are some parameters or barriers to the number of people who can attend in terms of inviting people to attend. It's being hosted by MORC, but I do believe that the general public is not prevented from attending those town hall meetings, and that's next week. So I asked Sheila if she could to send out the details so that this board can participate if at all possible. The other one is really encourage the board to attend our other public events, and I do want to thank Ms. Newman and Mr. Lindemeyer for coming to our press conference last week regarding co-responders with the police departments, Auburn Hills, Bloomfield Township, and Birmingham. I'm using my cheat sheet, I have to admit. But thank you so much for attending those. Those are so critical to what we do, but also those are the ways that we can advocate for the public system. And that's also another thing that will be impaired if we don't have the public system. Those kind of programs don't get funded and supported the way they are through this organization. So the other thing I wanted to bring up is I attended the Medicaid Health Plan Conference a week and a half ago, and the legislative panel was probably the biggest or most important piece for our benefit, and that was a panel with Shirkey and 4 other senators participating. And I have to tell you, there was a lot of talk about privatization and the benefit to the provider in terms of keeping them whole, but I don't think that, it was really not my place to say. I think there's a lot of misinformation there, but I do think there's a lot of misinformation in terms of comparing that system to our system. It's apples to oranges. They really are not looking at the benefits of the system, at the public system, and all the programs and services that go in the public system. And the last thing is next week I'll be attending the CIT International Conference. And that conference really is critical for us to become a crisis intervention training hub. Right now, we do have police officers in the community that are trained in CIT, but we really want to be the hub. I think what happens a lot is that we offer the training and then others take it on and they continue, and it loses some of the fidelity. So that's really one of the goals and things that I've pushed internally, is that we really want to build internal expertise and hold on to that. So that next week at that conference, it'll be interesting because all of the police and law enforcement community members I mentioned that were a part of that press conference will actually be present at that CIT International Conference, and as well as many others from all across the state. And then also the president of NAMI is also a CIT International board member. So we really want to build those connections and those relationships so that we can get a gold seal to be a CIT provider. And so that's the other thing that we are working on by being present in those events and really networking so that they understand that the CIT for Oakland County really is an Oakland Community Health Network training. So that's all I have in terms of updates. Just wanted to let you know where I would be and what's going on.
Just to comment on that press conference, I would have attended it, but the first I ever heard of it was 15 minutes. I got an email and it said yesterday, but I didn't get it yesterday. I got an email and it was to start, and I said, what's the time? And I looked and it was 15 minutes. So I don't know if Eric got it, other board members. I knew about it, but I didn't know the date or anything. So Eric, how did you know that?
Pardon me. I think Sheila may have sent an email to me to my personal email account. I think something was sent out through Boardable, and then she followed up. And I think I got the email the day before.
email that went out the week prior and then a reminder email. So, yeah, we'll do a better job of making sure we communicate that in a variety of different ways. And one of the other things I was going to say, too, is really wanting Christine and maybe a member of her team, if she's not able, each board member just telling you what's happening that month. Because we have a lot of things coming up this month.
I would also, this is Jonathan, I would also remind everyone to go out to Boardable and make sure that there is a notification from there that goes to your private email from Boardable.
I signed up for that, but now it says undeliverable.
Oh,
And Sheila gave us a text sheet saying that says that will be.
okay. Well, that would explain why I'm not seeing them either now. Okay.
This is Sheila, sorry. I can work on, there's original boardable post on 7/28, and then I just sent out a reminder post on the day before, and then I actually text most or all board members about the meeting the day before. But I can work with you guys to see what's going on, because we shouldn't you should be receiving them from your OCHN email. So we can work with and see what the issues are.
All right. John Paul?
You're on mute.
Sorry about that. Can you hear me now?
Yes.
Okay. I wasn't able to attend either, but I just wanted to mention that I did see an article in the Oakland Press about the press conference. So I get the e-edition, and I think it was on the front page actually of the e-edition. So we did get coverage on it, which was good, and it was a nice article. So I think press conference was good to bring notoriety to this initiative. Unfortunately, I was not able to attend, but we did get some coverage in the Oakland Press on it. Thank you.
All right. Thank you. Okay, we will move on to our second opportunity for public comment. Is there any public comment?
Nope, there is no additional public comment in the chat for this evening.
All right. Thank you. All right. And now we have time for board member comment. Sheila, if you could go through the roll, please.
Sure. Mr. Furman?
Yes, I really wanted to thank everyone for their presentations tonight, including the quality presentation as well as the financial presentation by Anya. I really thought that the presentation by Ben tonight brought new urgency, if it is at all possible, to the restructuring presentation, and really laid out in a way that I had not heard before. The whole sense of what could happen if either the Shirkey or Whiteford bills go through, and hopefully we can communicate that urgency to people served as well as their local lawmakers. Thank you. Have a good night.
Dr. Hans?
I have no comments. Thank you. Have a good evening, everyone.
Mr. Cowan?
No comment. Thank you.
Ms. Bernard?
No comment, thank you.
Mr. Torres?
No comment. Thank you.
Ms. Naomi Dyer?
No other comments, but it was nice to see everybody in person for the first time. Thanks.
Mr. Landsman?
Just a couple of things. First, I would like to thank everyone that presented. I know it's a dry subject talking about stats and quality and measures, but Marquita and Wendy, I think you guys do a pretty good job at bringing it alive, so thank you. The others, we are not going to cancel the study session. We will have a study session on Thursday the 26th. We will be covering the budget, so just make sure it's on your schedule, guys, board members, sorry. And then last is, there was a line that I used to hear a lot: vote early, vote often, and I would just paraphrase that to say, go out to cmham.org, the association, go look up where and how you can reach out to your legislators. I do it pretty regularly. I believe there's also a function there that gives you phone numbers. If not, there's a number of state Google ones that allows you to leave voicemail. I already have my state senator on speed dial, but please reach out to them, reach out to your county commissioner, so that they too might reach out to the legislators. That's our only way to keep this front and center, so that we can put a stop to this and seek alternatives that make more sense to the folks that we serve. So that's it. Thank you.
Ms. Newman?
Thank you. The only other comment I want to make, there's going to be a peer town hall with Senator Whiteford next Monday at 12 noon, a Zoom call. If anyone is interested in participating with that, it's geared towards people with lived experience that work in the system. They can contact me and I can make sure that they get the information on how to join that call. Thank you, everyone, for your presentations, and have a wonderful night.
Dr. Todd?
I have no comment.
Mr. Lindemere?
No comment.
Dr. Guadalupe?
Yeah, I would just like to thank everyone for their presentations and appreciate the legislative update, and hope that we all continue to advocate for those that we serve and those in the community. Thank you. And with that, I will call a motion to end our meeting.
Wait 1 second. Can you hear me?
Oh, I'm
Yes.
sorry, Ms. Root? Are you on?
Yes. Okay. I joined by phone at about 5:40 p.m. I apologize for being late, but I'm here. I'll make sure to go back and watch the recording. So thank you. Have a great night, everyone.
Thank you. All right, with that, do I have a motion to adjourn our meeting?
So moved. Jonathan?
Do I have a second?
Steve Todd, second.
Thank you. All right, our meeting is adjourned. I hope everyone has a great evening, and we'll see you at the board meeting. Thank you.